Welcome to part two of this Moving to Value Alliance webinar titled Health Systems at a Crossroads. My name is Dr. John Rodas, and I have the honor of serving as the president of MTVA. For any viewers new to the Moving to Value Alliance, MTVA is a nonprofit 501c3 corporation whose mission is to cultivate a healthcare ecosystem that prioritizes high-quality outcomes at affordable costs for employers and consumers. We urge our attendees to learn more about us at movingtovalue.org, or you could follow us on LinkedIn, sign up for our emails, and subscribe to our podcast, Moving to Value Unscripted, MTVA Unscripted, which can be found on all major listening platforms. Just a reminder, if you missed part one of this webinar, it could be found on our website at movingtovalue.org. Today's webinar is being recorded and will be available to view on our website. We're joined today by my fellow board members, Dr. Steve Schutzer, and one of the founders of MTVA and president of Upswing Health, and Lisa Trumbull, president of Sohn Health, Southern New England Healthcare. Steve will be curating any questions you submit through the Q&A function on our platform. Please use the Q&A function to submit your questions. It's my pleasure to introduce our moderator for today's webinar, Dr. Marion Couch. Dr. Couch is co-founder and CEO of IntoValue, a company forging direct-to-employer value-based partnerships between health systems and self-insured employers. A surgeon by training and former senior medical advisor with the Centers for Medicare and Medicaid Services, Dr. Couch brings deep experience in value-based care, innovation, and system transformation to her work advancing more effective employer-driven care models. Marion, thanks so much for joining us today and being our moderator.
Thank you, John. I will be introducing our three panelists after asking a series of challenging questions to sort of set the stage for the discussion. We today are blessed with three very accomplished leaders in three very different sectors of healthcare. They're perfect to discuss how health systems are innovating and moving towards value. So let me set up sort of a large question that we might talk about. In 2023, Health Affairs Scholars published an article entitled, "Why is it so hard for academic medical centers to succeed in value-based care?" It outlined a number of challenges, and then it ended with the following quote: "As the share of fee-for-service reimbursement shrinks, academic medical centers that are unwilling or unable to play well in the value market will likely focus on the high acuity cases, essentially becoming focused factories for surgical, transplant, and ICU care." We know that health systems, and again, that was about academic medical centers, but broadening it to health systems, are critically important to their communities. They provide the care. They're often the largest employers. They're subsidizing important service lines. They educate and train future generations, and they engage in research, which in and of itself has an ROI to those communities. But here's the challenging question. Are health systems becoming dinosaurs, clinging to fee-for-service? Are they entrenched? Will they become acute care factories? So to help answer that, I'd like to introduce our three panelists. The first panelist is Dr. Mark Gwynne, the Chief Value Officer at the University of North Carolina Health and the president of the UNC Health Alliance. I met Mark about 5 years ago when I was at CMS, and I called Mark a lot. I realized he was someone who's accomplished and truly understand how population health and value-based care worked. The next panelist is Jeff Hogan. He's president of Upside Health Advisors, where he's worked with employers, state health plans, startups, payers on navigating value-based care and health benefit strategy. He's also the managing director of fiduciary services at Homa Health, and he found time along the way to be the mayor of his hometown and also was a first responder at 9/11. Blair Childs, the third panelist, is president and CEO of Childs and Associates. He's a veteran healthcare policy strategist involved in multiple major initiatives that the nation has undertaken. He spent more than 2 decades as the senior vice president of public affairs at Premier, and he's currently advising many CEOs of health systems and major C-suite executives. So let me start with Dr. Gwynne. Mark, could you please tell us what UNC Healthcare has done in the value-based care arena?
Thanks, Marion. What a pleasure it is to talk with you all here, and I've appreciated the time over the past 5 years I've spent with you specifically. I think this is a great topic and one that we have debated internally now for a long time. And I think foundationally we had a decision to make about 5 years ago. Were we going to be part of the problem, or were we going to be part of the solution? And we are the center of high cost, inaccessible care. So we had to decide, were we going to really flip that and start to think about affordable access that's equitable to all levels of care to help support our core mission of caring for the most complex patients with the really significant service lines, developing the workforce of the future. So I'm grateful that my colleagues were willing to pivot. We're a large academic health system. We're about a $10.5 billion system at this point. Over the last 15 years, we've grown from 4 hospitals to 20. We employ 3,500 physicians across the state, both in our academic practice as well as a large community-based network across North Carolina. We have assets in 52 out of 100 counties. And we have a core mission as the state's health system to be the safety net hospital system and primary care system across North Carolina. I'm really grateful that we have invested in primary care for many years. For 3 decades, we've invested in primary care. As the kind of the core of our network and our system, that's coming into play really significantly now. And as throughout that growth, especially during COVID and coming out of COVID, we faced a lot of headwinds, just like every other health system in the country. And we faced a choice. Did we contract into what you described, Marion, or did we really think about growing our way out of these headwinds? But growth in a non-traditional way, meaning capital growth in bricks and mortar and acquisition is a typical health system strategy. But we pivoted to say, yes, bricks and mortar is important, but partnering with independent practices across North Carolina and supporting the medical ecosystem, supporting the communities that they served was really important, not just to us as a health system, but to the health of North Carolina writ large. So that's what we did. And we launched a statewide clinically integrated network. We're now that has about 5,500 physicians across the state. A third are independent, 2/3 are employed. We adopted a value portfolio that started with a small Medicare ACO and tapped into the academic ethos of let's be on the cutting edge of figuring out this population health thing and the financial model behind an ACO structure. And that was really interesting and important and got the attention of our academic physicians who like to innovate. And we've expanded that and really built that into a portfolio across all market segments, about 14 value contracts, covering 600,000 lives, 450,000 of which are at downside risk. And that's across an academic practice, a community practice, and an independent network. And has allowed us to be really flexible in designing care to meet the needs of those populations, but also to perform fairly well financially. And this hedge of value, as my CFOs like to call it, against our fee-for-service business, has really allowed us to net positive. And that's the way that I can talk to my CFOs across the system about value-based care. Yes, it is absolutely the right thing to do in terms of population outcomes, but it's net. And as we face these fee-for-service headwinds and pressures to shift into ambulatory care, I can articulate a business case through value-based care where that's actually to our net benefit. And we've certainly faced some headwinds. We've had some really significant facilitators to doing some of this work. This concept of policy change to shift us and to really force us into ambulatory care in a traditional fee-for-service historical health system lens, that's a challenge. But if we blend in the potential benefit around value, then it becomes I can articulate that really that quite well. We've had to really present some level of financial transparency and the ability to translate some of those net gains directly to our physicians. What's been fascinating is, yes, there are some of our physicians who use those dollars for compensation, personal compensation, but the vast majority across our network are reinvesting it into their practice. Both our employed and our independents. That tells me something, and it tells me that this is a new way for our physicians to operate. What they really want, they want their practices to be successful. They want to build the care teams around themselves that allow them to do what they need, what they know needs to be done. I quote that study all the time that says a primary care doc needs 26 and a half hours a day to care for all the needs of their panel. Well, with a care team, an extended care team, perhaps not, right? And so that's been really interesting because it tells me how we can incent our networks a bit differently, and create a different financial model. It's a growth strategy for UNC Health, affiliating with practices both with data, transparency, and coordinated care, has allowed us not just to build out primary care and specialty care, but to really dig into the entire continuum, meaning what happens in the pre-acute space, how we redesign care in our emergency departments, what happens after a patient leaves the hospital, post-acute and good transitional care. And it's really kind of come full circle to say the role of health systems, in my mind, are to really pay attention to that entire continuum and redesign the incentives across that continuum to drive better outcomes. North Carolina has been a bit of an experiment. It's been a bit of a lab over the past 5 or 6 years with third-party providers coming and going throughout the state, and smaller ACOs that have done really tremendous work and seen significant outcomes, and driven change 10, 15, 12, 15% performance to benchmark. What I need to do is shift our system by 1 or 2%, and that drives really significant population change in outcomes. And that's different. It's a different perspective and it's a different lens. And as we've expanded across the state, we're starting to see a bit of a pull from partners, whether it's other health systems, whether it's employers. And I know that a lot of the work that you all do with employer-based care and health is really important. We're starting to see a pull from employers to say, how can you as a health system, given what you've built, help us drive access, drive affordability? And what about this pharmaceutical cost thing that's really driving everything? And as an academic health system who benefits from 340B, and I'll put that out there, I think there are ways that we can innovate with employer partners that is fundamentally different than a decade ago. So when I start to look at policy and other things that have both can facilitate our work and potentially also act as barriers, I'm a big fan of V28. The amount of time and effort that systems spend on risk capture, that Medicare Advantage spends on risk capture, if we can lower the pressure on that and make it rational, I can shift a lot of my time and effort to actual care delivery and population outcomes. And I think that's really, really important. We think a lot about policy that shifts to ambulatory services. So site neutrality. I'm glad my CFO isn't here because what I'm about to say may sound a little odd. I'm a big fan of site neutrality because it forces us to shift. It forces health systems to shift. And quite honestly, that's what we need. If we don't have a real incentive to change, it's really easy to slip back into our old model of care delivery and old ways of thinking. And I could mention a couple of more. CON chain policy is changing in North Carolina. That creates a level of competition that makes us step up our game and gives folks like our state health plan options and disruptive options to really shift the cost of care across North Carolina. So it's been an exciting time, a time of growth for us, but within this dynamic environment right now, I think we've created a bit of agility that we can. I like to use the analogy of a catamaran. When fee for service is really helpful, we can shift into that. We can lean into that a little bit more. When there's value-based care options, we can lean into that more. The goal is to find where they overlap and jump through that window as quickly as possible. So exciting times, dynamic times. I'm thrilled to have this conversation with you all.
Mark, that was just perfect. And thank you for giving me now a metaphor so I don't have to use the foot in two canoes thing. So the catamaran is infinitely better. Thank you. I want to remind the audience that if you put questions in the chat, we will have time for them at the end. And I'm sure Mark's wonderful presentation will generate some questions. Next, I'd like to ask Jeff Hogan. You have a very unique perspective. And could you tell us about some recent developments that will impact health systems from your point of view?
Thanks, Marion. Thanks. It's great to be back with my friends at the Moving to Value Alliance, having spent more than 6 years on the board. It's great to see that you're continuing to educate on value-based healthcare, and I think it's more important than ever. Last week's webcast was spectacular, and really teeing up many of the issues that we're going to talk about here today. So by background, I've been in healthcare for 40 years, working on both the supply and the demand side of healthcare, working with care delivery organizations and health systems around the country, and also very large employer populations, state employee health plans, captives, Fortune 500 companies, and also middle market groups around the country as well. And literally, this is the first time in 4 decades, literally, that I think there's a true opportunity to change healthcare in a positive way. And there are really a number of forces that are driving that. It's almost like we've forgotten it, but COVID really impacted health systems. Mark, you certainly know how the health systems were impacted. Dr. Rodas certainly as well. Many were shut down, only offering emergent services and COVID related services, and huge staff and financial burdens that occurred because of COVID. And I claim that it really demonstrated the existential threat to health systems for being dependent on volume fee-for-service reimbursement. It really was the smack up against the side of the head to say, guess what? This isn't going to work on a go-forward basis. We have to do things differently. Secondly, and most of you know I'm obsessed with this, the Consolidated Appropriations Act of 2021 fundamentally changed employers' responsibility. It doesn't mean that it changed employers. It changed their responsibility relative to the management of their health plans. So named fiduciaries, typically one person in the organization, typically the CFO of the organization, were suddenly forced to have personal liability for cost, quality, outcomes, procurement, accountability in their health plans that were traditionally managed by HR folks in the plan. The named fiduciaries take on personal liability, and that liability actually extends to boards of directors. Most companies still have not realized this. They're slowly starting to realize it with lawsuits and other types of things. But the CAA is a big deal. And lastly, played out in Midtown Manhattan, big health plans, the BUCAs have really fallen out of favor. Most employers who are really going through huge economic pressures realize that the health plan generally accounts for their second largest expenditure after wages, and they can't control this element anymore. It's just something that goes to the bottom line that they can't control. So this year, for 1/1 effective dates, we're seeing many jumbo groups facing mid-teen increases. Just how do you do it? Nothing else increases at that level. So we refer to BUCA networks as a blunt instrument that generally don't service the very specific needs of employer populations. If we go back and look at the Consolidated Appropriations Act, it says you, employer, are getting a tax deduction. You're using your employees' money as contributions to the plan. You have a duty to act only in the best interests of your plan members. And you must, not can, you must secure the data on costs and quality and outcomes and fragmentation to make decisions in the interests of those folks for procurement, or you face legal liability in this case. So suddenly employers want more and better, and they're looking to health systems to give it to them. Expectations have changed dramatically. And these employers suddenly, because of technology and analytics, are gaining intuition into their needs. Mark, you said something that I thought was particularly important. We know how important population health is. I will tell you, having spoken to many boards of directors and C-suites within health systems before that are very proud of their population health analytics capabilities, that, and I said this very directly most recently, that employers don't care at all about population health analytics. They care about populations, theirs, their very specific population. And that's how things are changing. That's how the world suddenly is changing. The next thing is provocative. I've never been at a loss for being provocative, so I'll just do it here. Mark, I told you this was coming last week. Health systems are often and generally the largest employers in their communities. And especially after COVID, health systems have really had to work hard to retain doctors and nurses and other practitioners. Providers are in demand, and it's much harder to compete in their catchment zones for salary and for benefits as well. Here's the provocative part. Almost without exception, it's been my experience, again, anecdotally, that health systems as employers are among the worst purchasers of healthcare that I've ever seen. Honestly, they've trusted their BUCA partners to take care of them and do things differently. And I'll tell you that most of these health systems, they design their self-funded health plans to incentivize the use of that system's care delivery assets. Yet many of these get very tepid utilization in this tier, primarily because they don't understand their own costs or information around the quality of specific service lines, or even issues around access and patient-reported outcomes by service lines either. It's really astonishing to me how little insight these systems have around their own issues, how they're contracted with the BUCA that manages their employees directly, and the contracted terms and provisions are among the worst that we've seen in the market. And often health systems will stay with the same BUCA for decades and not go out to bid and not be aware of getting boiled like a frog as the provisions get worse and worse and worse and more confiscatory as we go forward, without accountability for any of these provisions. So often these health systems' most profitable service lines are the same places targeted by the BUCAs for revenue extraction from their own employer plan via the TPAs, including med pharmacy, and even on 340B, we see spread now that the carriers will take on that as well. It's really astonishing to me. And often these plans are giving up most or all of their rebates worth millions because they're never bothering to review the terms of their base contract. So ironically, all of the things that employers on the demand side of the equation are going through to become good fiduciaries or stewards for plan health assets are also occurring on the supply side with health systems as employers. I will say the veil is lifting. Health systems are really finally availing themselves of the same intuitive analytics technology that other employers are using, and they're shocked at what they're finding. I will tell you though, I love it. It's skin in the game. It makes them really more empathetic and relevant to the needs of employers on the demand side. C-suites and boards of the systems are really starting to pay attention to this as well. So what we're seeing with health systems, at least what I'm seeing around the country, is that many are now really heavily investing in analytics and technology to do direct contracting for employers in their catchment areas. Some are starting small by showcasing ambulatory assets, like Dr. Gwynne described, directly to employers to cover high volume episodes with lots of variation, arthroplasty, freestanding infusion, things that have huge and immediate impact for the employers that they're going after. Huge and immediate impact. Others are already in the process of creating captive arrangements by cutting out the BUCA altogether, anchored by their own health plan population. Again, skin in the game, designed to align their care delivery with the unique needs of the specific employer populations, thereby taking the risk from employers. So it's a big deal, and we're seeing it happen. So this is the start of a very large transformation, actually. We've never had a functional healthcare marketplace, and now the perfect storm created by the confluence of regulatory requirements, broad carrier mistrust, and financial needs and conditions is forcing the alignment of supply and demand. And curiously, the transformation is helped because of rapid and significant advances in technology, especially AI, both agentic and ambient. And I'll conclude just with some specific citation. Yesterday, Chartis published the 2025 Digital Transformation Survey, quote, predicting health systems aim to shift from reactive to proactive care delivery with it over the next 5 years. 9 in 10 executives say they must fundamentally change how they operate over the next 5 years from reactive to proactive care delivery if they are to remain viable. I'll stop there.
Jeff, it's a perfect segue from Mark and now to Blair. Beautifully stated. You've covered so many important recent developments that I do agree with you will be transformative. Before I hand the baton over to Blair, there is a question and answer function. If any of you would like to put some questions in there that we can come back to at the end for both Mark, Jeff, and Blair. Now, pivoting to Blair, as you speak with health system senior leaders and CEOs, what are you seeing in terms of innovation, improvement of outcomes, and some of their concerns? What are you seeing as a response? Because I can't think of a better person to sort of broadly speak about the pulse of what these leaders are looking at.
Thanks, Marion. It's great to be here, and it was wonderful to hear Mark's presentation because I'm going to be able to build on that quite well. So in terms of the drivers are and what I'm observing in the market, I should just mention too that on the introduction, when Marion referred to me as working at Premier, I was working with 4,000 hospitals and health systems. So I had a very broad perspective of what was going on within those organizations. And I've seen really positive developments that have been going on. And we certainly have already heard that from prior presenters. But there's really 3 major factors driving this. And of course, in healthcare, every market is unique and is based on a lot of internal factors to that marketplace. But overall, and the point that Mark made about, the OBA, the recent legislation that passed, or I should say legislation that has passed recently, is putting a lot of financial pressure on the marketplace overall. So that's one of the drivers, writ large, is financial pressure on the Medicare marketplace overall. Medicaid marketplace because of OBA, the One Big Beautiful Bill Act, and then employer marketplace, and of course the exchanges as well. Just a lot of financial pressure, which is driving this overall market change. But let me just touch on three major forces going on here impacting the marketplace at all overall. First is the Medicare Advantage, and these are policy changes. As you all know, the way Medicare Advantage works, it has a capitated payment to the plans. They're a fixed amount of money. There's been increased focus over the last number of years here to bring down what is seen as an overpayment to the Medicare Advantage plans. So they have flexibility because of the capitated payment, and they also are under increasing financial pressure, and they want to grow in the marketplace. So they're looking in a lot of ways, and they have the flexibility because of the capitation to do things like buy physician practices, build home health programs, telehealth, invest in a variety of different areas, and that's helping to drive a lot of private equity capital being expended in healthcare, and that's another disruptor force that's going on in the marketplace in general, as well as many larger physician groups are realizing that for them to compete in this marketplace, they need to take risk, they need to be accountable, they have to show their results. So the marketplace is driving this in part because of this pressure in all these different payment silos that we have in our healthcare system that make our healthcare system so difficult and complex. Again, Medicare, Medicaid, employers, and the exchanges. Then there's some specific Medicare steps that are being taken right now that everyone should be aware of that are helping to drive this movement to value-based care. One is, of course, ACOs, and everyone's aware of how ACOs function, but they hold providers accountable. It's mostly primary care providers who are actively involved in these ACOs. And at this point, 77% of the primary care physicians, probably more actually, because it's continued to grow, but are in risk-based ACO models, and in one way, shape, or form. And so they're aware of, they're involved in, they're experiencing value-based care themselves. So that's changing for those providers, those primary care providers. On top of that, you've now got these new models that are coming out of CMS that are amazing in that they are unusual that a Republican administration would do a mandatory model, but they are doing mandatory bundle payment models. There's the team model that starts in 1/1/26, which is 25% of the hospitals will be required to participate in this. It's got 5 episodes: lower extremity joint, surgical hip, and spinal fusion, coronary artery CABG, and major bowel procedures. So these are mandatory programs. It holds the hospitals accountable for the total cost of care for a 30-day episode, Part A and Part B spend. So this is going to force a lot of physicians to be in accountable markets or accountable arrangements that is going to help really, I think, shift the entire marketplace for specialists overall. So that's one specialty model. The second one that's very significant is this ambulatory surgery model that was included in the physician fee schedule rule that just came out a little over a week ago. It's a 5-year model. It's mandatory as well. And this, again, coming from a Republican administration. 2027 to 2031, starts in 27. It holds physicians who are involved in heart failure and lower back pain procedures accountable for the cost, quality, performance improvement, and interoperability measures. And 50% of the measure is the cost measure. So this is they'll be held accountable. It starts at no risk and it moves up to 12% upside downside for these physicians. So this is going to be another change. I could very well see all of the specialists moving in this direction overall because it's called the Medicare Value Pathways. So understanding how that is set up, this is a model that I could very well see expand across all specialties. So they're testing it in these two conditions, heart failure and lower back pain, but I could see this expanding further. So market forces as well as CMS policy is sort of driver number one as to what I see going on. The second major thing that I see going on is sort of the financial upside that that providers are realizing that they gain by participating in these models. And this was addressed a little bit in one of the prior speakers, is that there are a whole number of specific policies that are being put into place by the Trump administration and have been in place, but particularly with the Trump administration, they are taking what I call a all of healthcare spending attack. They're trying to bring down spending across the board. So they've got what was referred to earlier, site neutral payment light, as well as site neutral payment specifically, but basically making it a disadvantage for facility-based physicians over independent physicians. So there's going to be a reduction in employed physicians in hospitals overall. There's the phase out of the inpatient only list. That is a list that means that only a procedure can be done in the inpatient setting. It's going to be removed. It's not going to be an overnight change, but that's going to increase competition on health systems. There's these prior authorization models that we never would have thought we'd see in traditional Medicare. One's called Wiser, and the other is a prior authorization model for surgery centers. This is going to obviously reduce spend and profitability in those areas that they are focusing on. Price transparency, major trend that is still very immature, but it is affecting marketplaces and putting more financial pressure on providers. So all of those factors are driving what I call a realization that you should play what is a benchmark arbitrage. So essentially, when you think about a risk-based model, you're measured on your performance in prior years. You've got all these other forces bringing down healthcare spending. If you have a benchmark that's based on prior year's performance, you will actually benefit because all these other forces are going to bring down cost. So that's another major realization that a lot of health systems have gained, which is driving them to move in this direction. The third thing has been also sort of touched on in a variety of ways, is that there's really no way to build a high performance culture and organization without having a aligned, value-based, whole person accountable care approach. And I've heard this from so many leaders in health systems who point to, by doing this, they have started to move from what was discussed earlier as a sickness-based to more health-based healthcare system. This is obviously this MAHA movement in part, but I think it's a much broader thing that's been developing over the last decade in particular. But I think health systems are realizing this takes a lot of time and a lot of work. We've talked about data and data management. It's one component, but we have a whole infrastructure that was built up around a government-designed system, which is with Medicare payment and Medicaid payment, with all the CPT codes, DRGs, fee for service. The amount of infrastructure that has been built around this is really hard to change from. So it's understandable that it's been slow. It's also understandable that this takes time. So to build this long-term culture and to build a long-term performance organization that is really going to excel in this market, in this changing marketplace, organizations are realizing they've got to move the value, and that's why they're doing so. So some examples of organizations that I have worked with and I'm familiar with and seen what they've done that is really impressive, and they've gotten the same kind of financial return from this that others have alluded to prior to my speaking here, but Intermountain and they have Select Health. So they're what I call a payvider. They're both a payer and a provider. Select Health is an insurance plan, but Banner has done a whole payer component to their organization, and they've really moved the value quite effectively. Ochsner is another one that I think is a standout. Hackensack Meridian, Trinity Health, Henry Ford is amazing in what they've done, and Tri Health. So again, they're all moving in this direction. It takes a long time to get there, and they're starting that process, or they're not just starting it, they're in this process, but it's a 10-year journey because you've got to change your whole infrastructure, your whole approach. It's significant what's involved here, but I'm seeing extremely positive results financially, just like because of the forces I talked about. They're in a position to do better on these new CMS models for traditional Medicare beneficiaries. They're going to do better in terms of contracting with MA plans. And then they're also building cultures are focusing on attracting and retaining attributed lives as opposed to doing volume in silos, which is the way our traditional system has worked. So we're moving to that whole system, and I'm seeing some very positive developments overall. So Marion, thanks, and back to you.
Blair, that was outstanding. I think we've gotten three really important perspectives. And what I'd like to do next is I think we've got some questions from the audience, but we'll take a question from the audience, and then I have a question I'd like to bring forward to the panelists as well, if that's okay.
Yeah. Marion, I got a question from the audience, and this would be for Blair. Blair, in the past, these Medicare bundle payment initiatives have yielded minimally better outcomes in quality and cost savings. What do you think is different with the expanded bundles to improve outcomes and
Yeah,
reduce?
it's a great question. And I've been super involved in this because I played a significant role at Premier in organizing our bundle payment ACO and other collaboratives that we ran to help health systems succeed. To be honest, the model was flawed, very flawed, because it wasn't mandatory. A lot of the organizations that voluntarily entered these models did so because they realized that their benchmark was already lower than others. So they basically were going to they automatically they arbitraged the benchmark, so to speak, just like I said earlier, but for different reasons. They were already a lower cost provider, so they were able to yield a result. So obviously, in those circumstances, you're not going to be getting additional savings for the government, but you will do well as a health system. And I know that the participants who were working on those models and helping organizations as conveners succeed in those models, what they would go do is go look at their spend in the market that they'd be compared to, and they realized that all you had to do is identify the systems that were lower cost, and you'd make money. And so you'd work with those organizations. So that's why there was minimal savings. That's why they didn't work particularly well. And that is why they have now moved to mandatory models. And I don't see them turning away from this.
Good. Marion?
Thank you. I have a personal and professional interest in the price transparency, and that's what I want to ask our panelists. In October of 2020, CMS mandated via the Transparency and Coverage Final Rule that commercial payers must post their negotiated rates with providers for over 300 procedures. And I have to share with you, at CMS, we did not actually know what would be the outcome of that, but we knew it was an important first step. So I'd love to ask the panelists what they're seeing in a round robin. I'll start with Mark and then Jeff and then Blair, what they're seeing in terms of price transparency with health systems. Mark?
Yeah, thanks, Marion. I want to make a very brief comment about the previous question. Blair, I think you were spot on. We're a team site. We've done a lot of work around inpatient care redesign, procedural redesign. But because it's mandatory, we have more surgeons reaching out saying, what is this thing I'm hearing about? And how can I get involved? Which is just fundamentally different than BPCIA or others. So I just wanted to echo your point. Marion, I think price transparency is fascinating. And I think there is a culture among physicians that they want to do the right thing. In general, most physicians want to do the right thing. But often they don't know what the right thing is because there's not the right data in front of them to make informed decisions. We also know that patients rely on their doctors more than almost anyone else to tell them where to go and what to do. What we found is that if our doctors know that a CAT scan costs $1,000 here and $3,500 there, that they're going to do what's right in the patient's best interest. So now we know, and this we've been in a culture of learned helplessness around cost and price, and we're entering into this world where we can't claim lack of understanding. We can't claim ignorance anymore. So we're shifting into a place where we now, if we're going to choose a higher cost site of service, it's an active choice because we know that now. And I think that is just a fundamentally different way of practicing medicine. It may sound odd coming from a facility-based physician, that how important this is. Through our lens, it also gives us, we can back into cost across our system, across our state, different payers, different systems. I know where I'm at a competitive advantage right now. And I can bring a network to an employer now and actually say, we are your right partner. And I can say it with legitimacy. And that's what we're doing with the state health plan, for example. That is, again, just a fundamentally different relationship. So we can use price transparency and become defensive, or we can use it as a way to really significantly grow our presence. And again, it's a choice not dissimilar to the choices that we've talked about previously. I'm grateful that we're making the choice to lean into it, and finally listen to our patients who are telling us, I can go to LabCorp and my labs are a third of what you're charging me, right? So overall, I think this is a really positive step in terms of affordability.
Thank you, Mark. Hey, Jeff, what are you seeing out there?
Yeah, the price transparency in a world of purchasers having no clue is pretty useless at this point. So it's not a popular opinion, and let me talk about this for a second. So we think about it. In the past, the folks that are responsible for procurement have been HR, and HR conveys that responsibility to a conflicted broker who is going to place the business with the place that they get the most compensation, unfortunately. And so in the past, there's been literally no insight for employers into their highest priorities. Is it hips and knees and babies and shoulders and cabbages? Is it J and Q codes? They're pretty clueless. So suddenly when employers are finally getting their data and taking the time with analytics to triage, there is some direction around this. And quite frankly, the transparency thing can help a bit, but not ultimately. And what we're finding, and Dr. Rodas knows this when we worked on the state of New Jersey employee health plans, 822,000 actives and retireds, when we looked at the episodes of care, for example, a knee that should cost $22,500 on average was costing north of $90,000. So there's no perspective. If in fact we're putting transparency out there and says this is our price, and Blair, by the way, Hackensack was about 30% more expensive than the norm in those places. So transparency helps us to start the discussion. I will tell you that as we get more sophisticated and as systems like UNC and others that are out there that allow us to exchange the retrospective data of an employer and have them look at it, they in fact can come back and say, we don't care about our $22,000 price. You're doing 400 knees a year. We're going to give you a better price. That's what functional markets do. And that's kind of the way things are going. So in many systems, we're still very elementary, trying to make heads or tails out of this transparency that's being published in the marketplace. But when the purchaser doesn't know what something costs, what it should cost, or what it could cost, the transparency doesn't help them a lot. So those systems that are helping employers to intuit their unique problems, bad quality, access, fragmentation, lack of primary care, lack of standard of care, are winning in this coming marketplace. The transparency on its face, it's good, it's helpful, but it's not going to solve the problem.
Thank you, Jeff. Blair, any comments? I know you
Yeah, just
had an initial presentation, but love
just-
for you to chime in.
yeah, just a couple of quick things. So I think price transparency has been not as impactful to date as it will be long term. I think it's going to be very significant, but the ramp of price transparency has been quite slow, in part because initially when it first came out, what the way the information was displayed was not standardized, and it now is being standardized. The penalties for not having complete data, having somebody accountable in your organization is required now by CMS. So there's a lot of things being done that are making the data much more useful. So it's important. We were talking about it within the context of hospitals, but it's also payer data is also available. So that payer data, you can see how you're comparing, just like was mentioned by Jeff and Mark. You can see the difference in how you're paid overall. So that's going to affect the marketplace. And we're just starting to get this data put together with all this myriad of data from the payers as well as the providers, the hospitals. It's getting put together in formats and systems so that you can really make comparisons. And so as a consequence, just all the examples that have been given heretofore illustrate the way that data will be used. But I think there'll be so much more information that will help direct patients to what are the best providers, both from, and this is part of that ambulatory surgery model, the way they're measuring physicians is at the individual level. You'll be able to look at quality and cost information much more effectively. If you're in a private plan, the private plans will help you understand where your better options may be from a cost and quality vantage point. This is just going to continue to mature over the years to come. And I just think it's going to be a game changer overall. That's my perception on it. So it's the understanding the data, getting it put together much better than it has been in the past, but then secondly, tying it back to both quality and cost overall.
Marion, just a quick comment. What Blair said was really important, and I know so many that are on this call really understand the value of quality. Leapfrog results came out yesterday. Again, here we are in Connecticut, one of the wealthiest states in the union, and we saw a hospital get a D rating. Okay. And I will tell you, with transparency the way it exists right now, we can't show the cost of bad quality. I certainly can show it in the data, especially for that hospital where that arthroplasty almost every time results in readmission and infection that costs twice as much as the underlying arthroplasty. So these are really important things. As the consumer or the purchaser gets more literacy and intuition into their own data and populations, that they will become more discerning.
I think that.
Jeff, I wonder if this is not dissimilar. Oh, sorry, Marion. I
Oh, go
apologize.
ahead, Mark. Go ahead.
I wonder, this makes me think, I wonder if this is not dissimilar to John Wenberg and the origins of the Dartmouth Atlas, right? Suddenly we saw that suppliers were driving utilization. Holy cow, who would have thought that? What will we see in the next 5 years based on this level of transparency? That drove an entire generation of reducing care variation. This could be the origin of something super interesting.
I agree.
Steve, do we have a question from the audience?
Yes, we do, and just a few moments left, so I'll try to keep the answer brief. This is for Mark. And Mark, are there any direct contracts for North Carolina employers that are part of your strategy?
Yes, that's the short answer. The longer answer is Jeff pointed this out really well. Jeff, I'm going to steal everything you articulated before about health systems as employers because it is spot on. Are very we have some small direct to employer contracts, but the truth is we need to manage our own employees first and prove that we can manage our own employees as a population around access, quality outcomes, and affordability, and increasingly go to market. We work very closely with the state health plan, one of the largest employers in North Carolina. It's also interesting. North Carolina has been a slow direct-to-employer state, just in general, even with large multi-state national employers. We're seeing that change. So I anticipate over the next 3 years, we'll see a market increase in direct-to-employer work.
Mark, I love to say that in 5 years ago was when I was involved with health systems. Not once did I ever hear a conversation about what do employers want. This is a really important transformation. It's exciting to hear. Steve, another question?
Yeah, Marion, I have another one, and I think it would be for Mark and probably Blair. Does a functional healthcare marketplace require independent physician practices? And if so, what are the partnership opportunities that might exist between the independent specialists and a large health system? What are the incentives? I'm just impressed what you've been able to create across all of these different stakeholder communities. How was that done? And is it important?
Yeah, I'll start. I think. Go ahead, Blair.
No, please.
I would say it's more than important. It's critical. And I think the truth is that demand is far exceeding supply in terms of the need for specialty services. If there's anyone that can get a neurology appointment within the next 6 weeks, tell me where. We talk internally that we will have solved the access challenge when my friends don't need to call me in order to get an appointment with a cardiologist. So the truth is, this is a supply and demand challenge, and independent specialists need to be part of the solution. It's in our best interest as a health system to have affiliated partners that we know provide high quality care, that we know have affordable access as a pop-off valve for our demand challenge. And super interesting. We've done that with dermatology. Several years ago, a new dermatology appointment was 12 months away. And that's not acceptable to anyone. So we created a network of independent dermatologists, and even within our own EMR, created a pathway for referrals to be redirected to an independent network. That is fundamentally different within an academic health system, but it's serving the needs of the population.
Yeah, so I would just add that it's absolutely essential, same point that Mark just made, that you have a network that includes the best of the best and that you're making referrals to them and so forth. That is just a reality in this environment because what we're talking about overall, when you think about all the presentations here, they've been about really a changing marketplace. Our marketplace is becoming We're moving from I said this earlier, but we're moving from a government designed to a market designed healthcare system. That's what's going on overall. And everything we've been talking about is driving that. And so when you think about, what this administration is doing and what this is bipartisan. The Democrats are doing the same kind of thing. They started the team model actually, and they also helped design the surgery center model. All of these things are really moving toward a more market-based system. And one of the things that's in a market-based system that's being encouraged by this change in the way facility-based physicians are paid versus independent physicians. And it's a significant change in reimbursement, but that is going to, again, promote more independent practices. And you need to have all of these different providers in your network who are the best. And that's going to be more available in terms of the quality and the cost information, as I said. So not moving in this direction at this point is a huge mistake.
Thank you, Blair. I'd like to thank Jeff, Mark, and Blair for being such wonderful panels today. And then I think, John, you'll close us out?
Oh, thank you. Well, this concludes part 2 of our webinar, Health Systems at a Crossroad. I'd like to take a moment to thank Dr. Marion Couch for moderating today's webinar. A special thanks to our 3 guests, Dr. Mark Gwynne, Jeff Hogan, and Dr. Blair Childs. To my fellow board members, Lisa and Steve, for curating questions. And finally, to our executive director, Jacob Took, for managing this webinar and keeping us on track. And of course, I wish to give special thanks to our sponsors and supporters, whose names can be found on our website at movingtovalue.org. Thank you all for joining this webinar put on by the Moving to Value Alliance. Thank you for such a lively discussion. Thanks to all. Have a good day.